The next case is 52-year-old male with retroperitoneal mass. The patient presented with epigastric pain. A CT scan was performed and revealed an incidental finding of a retroperitoneal mass lesion adjacent to the right renal vein. The patient was scheduled for EUS FNA. We give the floor to Dr. Rosawa in the endoscopy room.
Okay, and now we insert the echo endoscope into the duodenum, the second portion. And here is a lesion about 2.5 centimeter lesion. There is a calcification, and the echogenicity is heterogeneous. We think this is abdominal tumor, very near to the pancreatic head, but doesn't look like a pancreatic tumor. We think abdominal tumor.
Yeah, as you pointed out, there's pancreas on the right side. So it's just freely mobile, separated from the pancreas.
It also, we wanted to look at its relationship to the duodenal wall, and to me, it looks like it is independent of the duodenal wall.
If it is from the duodenal wall, the possibility is disc. However,
it seems to move independently.
Yes.
And there seems to be an echo plane between. Do you agree?
Agreed.
Professor Rosawa,
Yes.
where are you in the duodenum? Is it in a short position or in a long?
now
Where in the duodenum?
long position, but not stable.
So when we pulled back, we were in a short position at 60 centimeters, and that was very unstable. We've now gone in, we're about 75 centimeters, and it's a more stable position.
Okay.
So we know from history it's been stable over a couple of years, right?
Yes,
And
about 2 years. Yes, 2 years.
so it doesn't look, just to talk through this, it doesn't look like a lymph node. It doesn't look like a bunch of lymph nodes coming together. It's not cystic. It looks solid.
Yes.
It's sort of looks avascular, or at least it doesn't have any color Doppler flow in it. Calcification, in general, statistically, is a sign of malignancy. It's sort of an inflammatory process.
Looks like some septations within, and the capsule seems to be clear. So,
definitely septations, or
Is this septation, you think?
well, not, it should. There are echogenic strands running through it.
I think one
think
possibility is schwannoma.
Schwannoma.
And you think the enhanced EUS is helpful for the diagnosis?
You mean contrast enhancement?
Yes, contrast, I mean.
I don't know. I don't think so. It doesn't seem to be very vascular. I think probably it's just means FNA, huh?
FNA?
If you really want to characterize it, I think we have to do FNA.
Okay, so
in Japan,
yes.
Do you have rows, or?
Yes, we have a pathologist stand by us.
very good.
Very good.
Yes.
On a Sunday. Very impressive. Very impressive.
So what type of needle would you plan
So what
to
goes
use?
through your mind when you think about the needle? 25
Yes.
gauge, 22 gauge, biopsy needle, regular needle? What?
I think we want to get more tissue, so I want to use at least 22 gauge. However, it is very difficult from this position. So what is your recommendation?
Well, whenever you're working the second portion of duodenum, you do need flexibility, and so the most flexibility is with a 25 gauge. But I agree
see.
with you. We don't really know what this is,
Yes.
and so it may require extra tissue. It's known that the 22 gauge will get a higher volume of tissue. So I think a 22 is probably what I would
22
go
gauge.
with. I think a 19 is too stiff.
Yes.
So you've
So
chosen a 22 gauge Olympus needle.
Yes.
Which is a nitinol-based needle.
Yes, yes.
So
It is consists of coil seats, so the movability is better, I think.
Well, I heard that the 19 gauge nitinol based needle is much more flexible, so
I think the movability is
because of the long position.
yes,
Yeah.
not good.
I agree.
Professor Ryozawa,
Yes.
what would be the differential diagnosis from this finding?
Very difficult. As Professor Ho said,
Yes.
many possibilities. I think lymph node, enlarged lymph node, and schwannoma, or is there
Professor
any
Professor
other?
Loser, could you summarize the basic diagnosis findings of this tumor? Tumor margin and then internal echo. So
The internal
Then
echo is
presence or absence of
heterogeneous, and there is a calcification, and not from the duodenal wall, and not from pancreas. So we think retroperitoneal tumor or another other abdominal tumor.
does this tumor have a irregular margin or lobulation?
I don't think there is any lobulation.
I mean, I think the heterogeneity of the lesion gives you an idea of lobulation. I don't think it's encapsulated. I don't see a definite capsule around it. There's sort of echogenic, very irregular margins around it.
Anyway, very difficult to say the diagnosis from
Thank
the
you.
imaging diagnosis.
So there he adjusts the sheath on the outside. You can see it in the upper right-hand corner.
Yes, this is,
And I think, yep.
here is a cyst. Can you see?
And I think I think it helps to brace the scope. You need to avoid the calcification. You can't go into the calcification.
Okay, so now I will puncture.
Professor Loser,
Yes.
could you tell us low echo area backside of the tumor?
Sorry. Now I puncture, and it is very soft.
So
So what we know about FNA, number one, the sample that's obtained will be better if we take different trajectories through the tumor. So rather than go in the same trajectory multiple times, we want to take various trajectories through it, maybe 3 or 4 passes in each trajectory. We are using suction here. In my own hospital, we have had studies to show that at least for rows, suctioning makes it more difficult for the cytopathologist because it produces more blood.
Oh, now blood coming.
So we not only ask the cytopathologist to come in on Sunday, but we give him lots of blood. So we're not very kind to our cytopathologist today. We're sorry.
Dr. Halls? Dr.
No
Halls?
problem.
Maybe
Dr.
the
Halls?
next puncture or without suction.
Yes, I would recommend without suction. As long as you make good passes through the tissue, in different trajectories, no need for suction. But suction produces a lot of blood, and this dilutes out the cells needed for making an interpretation.
Do you have any tips for fatting technique? That trajectory?
Yes, so the trajectory can be changed by either changing the
Wheel?
elevator or by changing the big dial, up and down
Yes.
dial. But
Which do you
if it's
prefer?
possible, you need to try to withdraw completely from the lesion. So if my fist right here is the lesion, if you're still in the lesion and you try to change the trajectory, you can't do it very well. But if you pull all the way out and then redirect, then you can get different trajectories. So if you can, it's best to pull all the way out of the lesion into the soft tissue around the area, change the trajectory, and then go in. But if the needle is kept very much in the lesion, then you really can't vary the trajectory very much with either the elevator or the up-down.
Okay, thank you very much.
So I think the camera is on the specimen. It's is it mucoid or no?
4回全部で戦死されてるわけですけど、そのうちのですね2回目の検体からここに今出ています粘液収容の背景とスピンドルセルですね、紡錘形細胞がこういうふうに見えています。でもう一つは上皮系の成分で、こういうシート状の細胞が上皮細胞が出てきれいに並んでいて悪性のものはないと思いますけど、これとそれから今最初に示したミクソマタスな成分が見られます。でこの2つが両方とも腫瘍の成分だとすれば、いわゆるその混合性の腫瘍になるんですけど、後腹膜なんかですと例えばテラトーマーの成分なんかもこういうのが出る可能性あると思います。それから上皮系のこの成分に関しては十二指腸から遷移されているので、その表層の上皮がこれコンタミネーションしたと考えれば、こちらの方がミクソマタスな方がメインであれとすれば、非上皮性の腫瘍の変性である可能性もあると思います。でいずれにしましても、両方の成分に分裂像がないということと、それから著名な異形がない、プレオモルフィズムがないということから、良性の病変で、しかも腫瘍性の病変の可能性が高いと思います。以上です。
Thank you very much, Dr. Kushima.